Hello, everyone. Welcome to the third episode of the University of Michigan Sound Support's Parent Webinar Summer Series. My name is Emma Brooks, and I am the Sound Support Coordinator for the University of Michigan's Hearing Rehabilitation Center. I hope you all are having a great summer. As many of you are aware, Sound Support is an outreach grant funded by the University of Michigan Department of Otolaryngology and Michigan Medicaid. The grant is designed to provide outreach and support to children with hearing loss throughout Michigan. We've put together this series of webinars for parents due to the great responses from last year's series. We hope that you'll find them to be helpful, and we encourage you to share topic ideas for future discussions with us on our evaluation, which will be sent out in the next few weeks. We strongly encourage your feedback and suggestions. If you would like a copy of the presentation slides from today, please email me at oto-soundsupportci@med.umich.edu. If you have any questions, please email them to me as well, and they will be answered in a live Q&A portion of this webinar that will air at a later date that is yet to be determined. Today's webinar is titled, Applying Behavioral Strategies for Children with Hearing Impairments. I would like to take the opportunity now to introduce our presenter today, Dr. Marie Van Tubbergen. Dr. Van Tubbergen is an assistant professor in PM&R. She received her PhD from Central Michigan University. Her internship was at the University of Massachusetts Amherst, and she completed her postdoctoral fellowship here at the University of Michigan. Dr. Van Tubbergen is the psychologist at Med Rehab Milestones Neurorehabilitation Program, an outpatient rehabilitation program for pediatrics. The clinic provides multidisciplinary therapies for children and adolescents with congenital. I've got Dr. V right here with me. With congenital and acquired neurological injuries. Her research interests include development of adapted techniques and accessible measures for use in neuropsychological assessment. She is a co-investigator on 2 federally funded grants through the Michigan Adapted Cognitive Assessment Lab, which evaluates psychometric properties of adapted neuropsychological tests for use by individuals with speech and motor impairments. Currently, she is refining assessment processes to examine phonological processing abilities and ADHD symptoms among children with speech and motor impairments. Dr. Van Tubbergen is the president-elect of Section 1 Pediatrics of APA Division 2 Rehabilitation Psychology. I will go ahead and hand it over, and we will get things started.
Thank you, Emma. Hi, everyone. This is Marie, and Emma, I have to apologize. That was clearly an outdated blurb, so I'm sorry to put you through that, and everyone else too. Today, we're going to talk about applying behavioral strategies for kids with hearing impairments, and there are 3 basic goals that I'm hoping to offer today in this talk. And the first is to just describe the basic components of a behavioral intervention. And the second would be to give you 3 common strategies or building blocks for different types of behavioral interventions among children with hearing impairment. And then at the end, go through and identify and list some red flag behaviors or some key behaviors that might indicate that some professional help is needed or that the behavior issues go beyond strategies that might be used in an everyday school situation. So we're going to start today by looking at evidence for the behavioral concerns among children with hearing impairment. And this is really to help us back up and look at the big picture of behavioral concerns in this population. So Sanusin published a large retrospective study looking at self and parent-reported behavioral problems among hearing impaired groups and normal hearing groups who were comparable for age. They were all average age of about 12. They were comparable for gender and for SES, or which stands for socioeconomic status, as well as comparable for nonverbal IQ scores, although unsurprisingly, the language skills for the non-hearing group, or for the no hearing loss group, or the normal hearing group, was greater than that in the hearing impaired group. And when we were looking at the results of the study show that children who have hearing impairment are at a higher risk for emotional and behavioral difficulties than normally hearing children. that there were, somewhat surprisingly, no significant differences of the rate of emotional or behavioral symptoms, regardless of the level of hearing loss, whether it was moderate, severe, or profound hearing loss. And then finally, children with hearing aids and profound hearing loss did have significantly more symptoms of aggression or sort of externalized behaviors than those that had cochlear implants. So by aggression, we mean proactive kinds of negative behaviors like kicking, pushing, hitting. So children with hearing impairment are more likely to have behavioral problems than peers, even through later elementary school. And the degree of hearing loss is not related to the risk of behavioral concerns. And when they did break down this study, they looked and saw that the risk factors were greater for older male children who came from lower socioeconomic backgrounds, had lower nonverbal intelligence scores, and had lower communication skills. So I think when we go through that, we ask, well, why is that? Why are these findings so robust? And the authors of the study really look to stigma and social rejection as being pretty key contributors to these negative behavioral and emotional symptoms. And the delays in speech and language really were contributing directly to behavioral problems. So when we look at the communication, there's refinements in the types of social language that we use. So using the tone of voice, how people modulate their tone, the pitches and tones to convey emotion, probably play directly into those social skills. So to bum up, we know that children with hearing loss are often reported by teachers and parents to have different types of relationships with other children than those with normal hearing. Other studies have found that preschoolers have fewer and shorter interactions than those of normally hearing children, and their bids or their attempts to interact with other kids are not reciprocated by normal hearing children at the same rate. Children with hearing loss do tend to interact more with children of a similar hearing status if that's possible. So when they look at mixed classrooms, it did appear that children with hearing loss gravitated towards interacting with each other. And then we also know that the relationship between intelligibility and peer perceptions of cognitive abilities are really strong. So as intelligibility improves, the peer perceptions become more positive. So to sum up this kind of brief review of the literature, we know that children with hearing impairments may encounter behavioral challenges in addition to the sensory challenges. We know that the importance of speech and language development has important social and emotional ramifications in addition to the cognitive and academic development. So to address the social and emotional risks that drive intervention along with language and hearing goals, or learning goals, most children with hearing impairment have routine interactions with speech-language pathologists, audiologists, and other professionals. And the goal is this really positive trajectory, right? We want to move from the discrete intervention and some speech-language or programming sessions. This leads to better access to education, leads to better development, learning, and growth, and leads to independent communication skills. That's, I think, the goal. Of interest today is when this trajectory is really interrupted and things get stalled out in these early stages of trying to intervene. Now, when we look at a picture like this, we can make a pretty good guess about how a child likely feels when they're in speech or when they're having a behavioral reaction. This is a child who's clearly in distress. And, you know, if you think about it, in a typical developmental situation, there's not really expectations for toddlers and preschoolers to participate in extended, regular tabletop activities, you know, other than eating. So, you know, many of the interventions that happen for kids with hearing impairment are actually not age appropriate in the sense of having to sit at a table and interact with certain toys. So even though they're maybe not age appropriate, they are clearly vitally important. So, you know, if we compare this to other kinds of health interventions that kids routinely go through, like vaccinations, we don't expect kids to buy into vaccinations or to support vaccinations, right? And so a child similarly is not going to necessarily or automatically buy into therapy. They would have no concept of the importance of sitting still and focusing on games and activities in therapy and learning. And that's true both in a formal setting in an office and also at home, the kinds of home exercise programs that parents like you are frequently told to do. And the difference, of course, is in vaccinations. It's relatively quick, and it's something that's done to the child. The child's not actually required to participate, but for the interventions in speech language and hearing concerns, the child is really expected to engage. So we know how the kids might feel, which is rotten, and we can make some guesses about how providers might feel too. Providers might feel some uncertainty about their abilities to manage behavior. They're typically trained in specific disciplines having to do with hearing and speech, not necessarily in managing behavior. I think providers often, I know from working with my colleagues, providers often feel extremely obligated that they're supposed to be providing the specific discipline-specific service, and spending time on behavioral issues feels a little bit uncomfortable or like outside of what they're supposed to be doing. And then also I think providers feel like they don't actually have explicit permission, or they haven't really made an agreement to intervene with behavioral problems in a way that feels like discipline to them. So I think providers might feel a little tentative about some of those things. And then if we imagine how parents might feel, and I welcome your feedback and corrections to how this sounds to you, but I think often parents are really embarrassed by their child's behavior. It feels like it reflects badly on them as parents. They might feel, hey, I'm bringing you're the professional, this is your specialty, you should be able to manage this behavior appropriately. And parents might feel insecure about their own discipline strategies, especially when it's happening outside the home. And then, of course, I think any parent is going to feel general distress that their child is unhappy in a really basic way. So this presents some really different challenges for parents and for providers. So I think sometimes when we are encountering a child who's screaming, or when you look at your own child who's screaming, when you're trying to do the intervention that you've been told to do, you feel a little bit like a deer in the headlights. So let's look a little closer at why a parent might feel some concern about their competency in managing their own child's behavior in public. And one of the things that I think doesn't get talked about very clearly, but when a child is born with a specific medical condition or a sensory impairment in this case, what happens is that a lot of the child's development gets assessed and monitored and treated by professionals on a really regular basis. And while all of this obviously is done with good intention, it sometimes might have the unintended effect that, giving the message that maybe parents aren't the expert of their child, and that parents might feel like, well, I have to defer to these other people in how to handle my child's condition and how to handle my child's behavior. So we also know that children with sensory impairments don't pass through the typical developmental milestones, and they may not pass them in the same order or on the same timeline. And then again, for parents, this is a tough situation because it makes making comparisons with their friends and their relatives, or maybe even with their other children, it makes those comparisons really unhelpful, and I think parents often feel isolated. As a little bit of a side note, I think this sense of isolation might be even more prevalent at this time. I think everyone talks about social media, and social media definitely presents us with just oodles of evidence about how all of our friends and acquaintances are blissfully enjoying the experience of parenthood. And in fact, we ourselves might even put effort into cultivating the same perception on social media about our own parenting experiences. And I think sometimes the contrast between the image and then the moment-to-moment experiences can feel really disheartening. So a parent might feel really distressed about any additional challenges or frustrations or sadness that a kid is experiencing, a kid with a sensory impairment, especially if it's an unpleasant feeling that could be fixed for them or taken away from them, an attempt to unburden the child in some way. And sometimes parents, I think parents, all of you do a good job trying to keep that distress internal, but I think sometimes that pressure or stress can be magnified from I have the quotes, helpful others, grandparents, other parents, friends, people who are trying to be helpful, they're trying to be kind, but they're maybe not doing the difficult kinds of behavioral management that a parent might feel they want to do. So, sometimes parents say no, but grandma says yes. And this can pose a particular challenge when parents are depending on these helpful others for childcare, for babysitting, or for other really important support. So I think, parents and professionals alike can identify that undesired behavioral makes sense. It's a logical outcome of a sensory impairment, but that doesn't make it mean that it isn't a struggle to identify the appropriate response to guide and shape that behavior. So that's where we start with some of the behavioral interventions. I promised you a review of 3 common strategies for handling hearing impairment. And the 3 that we're going to cover today I call the Science Fair 101, or Learning the ABCs, which is really a systematic analysis of behavior. And then the second is really setting helpful goals. And the third is using selective reinforcement, which is better known as timeout. So we're going to look at the ABCs first. And the ABC technique is one way to really gather important information about what's happening in a child's environment. It's a way of looking at patterns of behaviors, and using this technique can really help a family or a team and make changes in a difficult situation. So the A stands for antecedents, which is a fancy way of saying, well, what's actually happening right before the problem behavior occurs? And then there's the problem behavior itself. And then the consequences, well, what happened after that behavior? So it's trying to look systematically at what is happening in the real world. So taking the time to evaluate these behaviors systematically helps us form hypotheses about, well, what is a child potentially trying to communicate with that behavior? What's the child trying to accomplish? And when I say trying to accomplish, I don't actually think that children are scheming this in their heads or making a very conscious plan, but the behavior is really a form of communication. So when we know what the child might be trying to communicate, this helps us identify strategies to encourage better behavior. So I'm going to give a little example here. And if any of you have any experience with school programs, they do this kind of thing all the time. This is a really common strategy used in schools. And in schools, they're doing it in very specific ways of having someone sit quietly in the corner of a classroom and just make these observations. I think it's possible to do this, retrospectively as well, by just sitting down in a quiet space and getting out some pen and paper and trying to figure out what happened that day. So ideally, it's something that you do ahead of time, where you're really planning and observing very carefully from a distance, but I think you also can just do this in the evening when you're sitting around and trying to figure out what actually happened today. So here's a couple examples that I just came out for a kid. So looking at 3 incidents that happened in the morning. The child's playing with cars with his sister. The mom is getting ready to leave, getting everyone ready to leave to go to errands. And then suddenly the child is crying and throwing the cars at the sister. And what happens after that is the mom scolds them, and maybe scolds just the child or scolds both of them, but the result is a scolding. So, and then we look a little later, they're at the grocery store now with the mom and the sister, and the child refused candy. Their mom is, of course, the stores put all that candy right at the checkout, and so the child wants it, it's refused, and so next thing you know, we have screaming and hitting, this time at mom, not at sister. And so the consequence there, what happens there is that the mom, does some extra restraining or buckling in the cart and just tries to get the heck out of Dodge as quickly as possible. And then a little later, Dad comes home for lunch, and this is a little bit of a surprise, and the child's greeting and hugging Dad, and everything's great. And then all of a sudden, the switch is flipped, and the child starts to cry and runs away and goes hides themselves in their bedroom. And the parents, and this one the consequence there is parents attempt to comfort the child. So if this were an interactive presentation, I would ask people to volunteer their hypotheses, but as it is, what theories might you come up with about these ABCs, about what we're observing here? I think some possible hypotheses could be that maybe this behavior is most likely at times of overstimulation, where there's suddenly lots of things going on. Possibly this is really speaking to a difficulty with transitions, from transitioning from one activity to the next. And maybe there's just a difficulty in managing the sort of changes in activity levels, from going from quiet to excited and excited to quiet. So, I think these are three possible hypotheses. The truth is there could be many, many more. But if we were going to go with these three, then some possible strategies we might use would be, let's establish some picture schedules for the day. Let's try that, so that you have a little a picture schedule that shows what's going to happen each day, that's reviewed with the kid ahead of time, and maybe that will help. Maybe, in fact, we're going to establish a really common routine for some transition. So every time we leave the house, we're going to do, 1, 2, 3 things in a very specific order, and we're going to make a routine out of it. And then maybe also we're going to prepare an escape plan for a situation that we know is high stress, such as being out in public or trying to run errands. So the beauty of this kind of ABC systematic observation is that it isn't actually necessary to be correct right away. So the cycle is that you collect these observations, you form your hypothesis about what you think might be going on, and then you try and come up with some relevant interventions or some relevant strategies to cope with that. And then, of course, the next thing you do is you do this all over again. You actually try it out for 3, 4, 5 times, and you see if this makes a difference. So, after you repeat this process over and over, I think people really are led to some greater insight and understanding about what is driving the behaviors that are of concern. So like in clinic, when I work with families on this kind of method, we typically identify 2 or 3 interventions to test for a week. And when they come back a week later, it may be that 2 of the ideas really were kind of a bust, but the third one seemed to produce some positive changes. And so then that helps us narrow down what our hypothesis really should be and give us some more accurate interventions. So this first, behavioral strategy really is systematically observing what behaviors a child is doing and what they might be trying to communicate with those behaviors. This kind of leads us to our next really behavioral cornerstone, and that is setting helpful goals, or you've all probably heard this little acronym of SMART goals. And SMART goals are goals that are specific, that are measurable, attainable, relevant, and time-based. So let's take a look at what that might be in practice. So let's say in setting goals, my initial goal is that a child is going to learn to sit still and participate in therapy. Well, this is actually a pretty unhelpful goal. Why? Well, because it's way too broad, it's way too ambitious, and also it would be pretty tough to know if we were having success or not, because unless they actually sit and participate for the whole session, how will we know if that's successful? So a different kind of goal that is a SMART goal would look like this. So the specific goal is the child's going to sit still and read a book. And how will we measure this? Okay, well, the child's going to sit next to me while I read a book, and we'll turn the pages and point to pictures. And then the next one, is this achievable or attainable? Okay, well, let's scale that back a little bit more. The child's going to sit next to me while I read a board book, and the child's going to turn at least one page and is going to watch me pointing to at least 2 pictures. So really scaling back of like, okay, if the child's not sitting still at all for books, how can we break this down to an attainable goal? is this relevant? The R for relevant. Well, we know that interacting with books is really an important skill for language, for therapy, for education. So yep, it's relevant. And is it time-based? And so here we make a time limit. I'm going to work on this goal at least twice a day for no more than 5 minutes. And I think as parents, you are doing so many things. And I would say all of these components are important, but the first priority I would have is to really put some firm limits on how much you're expecting yourself to do toward any specific behavioral goal. So, twice a day for 5 minutes seems like a great plan to me. All right. So what you need to know about that kind of SMART goal is that the goals are going to change all the time. They're going to change daily, weekly, monthly. And, as clinicians, we work with parents to see behavioral change as a really important piece of therapy or educational achievement, right? So managing behavior is it's an ever-changing and elusive goal. But it is also so important because without these kinds of behavioral skills or this emotional self-regulation for a child, they're not going to be able to really benefit from any of the other educational or developmental opportunities that they have. So, I know in my own experience as a parent, one of the feelings I had when they were younger is that the second I was competent to, deal with a particular situation or guide my kids in their daily challenges, they suddenly would hit a little developmental burst, and next thing you know, all of the strategies that were working beautifully 3 weeks ago were no longer working. And I think that's really important to think about when we think about goals, is that no SMART goal is going to ever last over time. It's going to be changing all the time. The practice of making SMART goals is exceedingly durable. So for our last behavioral strategy or technique that we're going to talk about today is the one for selective reinforcement. So it's the first time today that we're going to talk about reactions or responses to behavior rather than the more proactive planning for behavior. So I think when we do that systematic observation and we're forming ideas, and then we're also trying to form these really clear SMART goals, these are all things that we're doing ahead of time, which is great. But then I think there's also the age-old question of, what do I do when my kid has a tantrum or a total meltdown? So let's look at reinforcement. So selective reinforcement is the intentional manipulation of the consequences of behavior in order to shape more desired behavior. So we can look at that in a couple different ways. The ones highlighted in purple here, that consequences can work by earning something desired or avoiding something disliked, we call both of those types of things rewards, right? So if I'm going to give praise for doing something correctly, that's earning something that's desired. If I want to set up a consequence that the child's able to avoid something they dislike once they do a behavior, that also is a reward. So if I say, oh, yep, you can leave the table after you've had 3 more bites of dinner, then they can leave something they don't want to be sitting at the table anymore, and they can do that by a desired behavior. And then there's the flip side of that, which is, I think, we commonly think of as punishment, which is that you earn something you dislike. There's a consequence you don't like after a behavior, or you lose something that you value. So there's sometimes, I think we can get really persnickety about how these, is this a consequence? Is this a punishment? Is this a reward? I think I'm just presenting this as a way to talk about there's lots of different ways to react to behavior, and if we're intentional about it, we actually can give ourselves a real advantage. So if we're going to do this, if we're going to try and plan the consequences for behaviors, whether they're positive behaviors that we're trying to reward or negative behaviors that we're trying to extinguish, we have to identify what the reasonable consequences are for that behavior. And so as a little example, right, it's reasonable to say, okay, I'm going to very intentionally give sincere praise for any attempt at a good behavior. What is not reasonable to say is, oh, we're going to go out for ice cream every time there's a good behavior, right? So one thing we want to do carefully when we look at consequences and make something that we really can use over and over again. And then, of course, it goes without saying, consequences only really work if there's something that the child cares about, if it's something the child actually really wants or something the child really doesn't want. And I will tell you, it's an age-old truth, and I think you guys know it too, although on a day-to-day basis it might not feel this way. But for most children, parental attention is absolutely the most valuable thing, the most common desired goal for any kind of behavior. And so I think, in my practice, I typically start with the basis that parental attention is really the most powerful tool I have to use in managing a child's behavior. And this will sound even more familiar when we put it in the term or the phrase that we use a lot, which is timeout. Right? Timeout is something that's been around for eons, and it is based on this idea of removing parental attention is indeed quite a punishment. So, timeout, I think everyone's familiar with the basic concept, but people say, well, how long should timeout be? What's the right way to do timeout? And so just some basic guidelines, if you're using timeout as your regular discipline strategy for just regular ups and downs, kind of your catch-all consequence, well, that might mean that you have a very specific time limit that you use. That's your default time. So maybe, I think the general rule is 1 minute per year of age. So a 2-year-old is 2 minutes, a 4-year-old is 4 minutes, etc. And that's fine. I think if we're using timeout for a really specific new behavioral goal, something like one of these SMART goals that we're talking about, then I think sometimes it's really useful to be flexible about timeout and maybe changing that up and making it really short so that it's something you could repeat over and over and over again without it turning into, hours and hours of the day. So the other thing about timeout, no matter where you're using it, you have to develop or you have to figure out a place. I think I don't know if Super Nanny's still on TV. It used to be on TV, but she used to call it the naughty spot. And, figuring out a place where this timeout is going to happen, and we want it to be a place that is safe, right? That even if a child is thrashing around, they're not likely to hurt themselves too severely. And also somewhere that is both easy to see, easy to monitor, but easy to monitor without the kid knowing that you're monitoring it. Because really, we want a timeout situation where the child feels like they really are not getting any parent or adult attention. So you're really not going to talk to a kid in timeout. You're not going to give them any eye contact. You're really, really going to do your best to look like you have better things to do. You're going to look calm. You're going to try and look like this is all just a natural part of life that doesn't bother you in the least. And so it's your chance to practice your acting child. I think all of these things is just to go back to the goals here when we're really thinking about letting a child get upset and find times to calm down. We're really giving them an opportunity to practice self-regulation. Self-regulation does not just happen. It does not. We're not born with this. It's an active skill that has to be developed. And so doing timeout is a chance for a child to develop that. So I want to move to a case study or give an example of a situation where we're using kind of all three of these things into a real situation. So I'll tell you about a young boy, almost 3 years old, that I worked with, who had bilateral cochlear implants at at under 2 years, so a little bit late actually. He lived with his married parents and 3 older stepbrothers. He had very few same-age relatives or other peer activities at the time that I met him, although I also met him right as he was about to start some part-time daycare. He had been making really poor progress in speech therapy, and really his behavior was such that there just wasn't even certainty that his cochlear implants were even working correctly. because they just could not do testing that led any confidence in the results. And then there was also, some real tension and some hard feelings because a social worker from a previous provider had told the parents that this child, Tim, had met criteria for autism spectrum disorder. And that goes in real contrast with, the father, who's the person I work with primarily. The father really had no doubts about Tim's overall abilities or his intelligence. And in fact, the first time I met them, if I just a growth assessment, his motor skills looked fine. And even though there had been this one review by one provider about being on the spectrum, the school's observational assessment that they had already done really just felt it was speech and behavior and social skills. They did not see this as autism. So there was some dispute about that. Again, there were some changes in the kid's schedule. He was about to have some more structure during the day, but really for the bulk of his waking hours, it was the grandparents who were taking care of Tim while the parents worked. So, and this definitely was a situation where I think the grandparents really struggled to set behavioral limits for lots of different reasons. So during my interview and observation of watching Tim play, it really seemed like actually had some very, very nice play skills. He explored things. He did not get over-focused on any particular thing. He could use the toys and solve problems and figure out how to use the toys he wanted to use them. So there were some really nice skills that could be observed in that systematic observing right away. Some of the other things I observed, though, is that Tim really had a strong sense of control, and really I noticed the behaviors really propping up as soon as someone else tried to guide or control or restrict his behaviors. At this point, he had no understandable speech. He had a couple signs. He didn't really make great eye contact. He had frequent, very loud tantrums, and he would fling his device, or he might bash his head against the floor during tantrums. So his tantrums were really significant and upsetting to people. And like I said, he also had some strengths. But I think the result of these really loud and sort of violent tantrums is that really the family had kind of gotten to a point where they were just tiptoeing on eggshells and doing whatever they could do to avoid those tantrums on a day-to-day basis. And there was also some family conflict about should we be doing this differently, and if so, how. So what we worked on as a team together was we decided we were going to try a 3-session approach, right? And so we used all of the behavioral interventions that I talked about today to form a plan for this really brief intervention. So first, we collected the observations. We had the observations from the school. We had the observations from the speech-language providers. We had the observations that I was able to make with the family right there. And it did seem as though the tantrums were triggered by attempts to control or direct Tim's activities. So, I think that was our hypothesis that we were working on. What we did next is, looking at a SMART goal to target, we were not going to change this kid's behavior 24/7. What we really, really cared about is we wanted to know if his cochlear implant was working. So that wasn't the only thing we cared about, but at the moment that was the most important thing that we cared about. So we picked that specific goal, and then from that made a series of other goals of how can we get him to participate in things well enough that we can do the testing. So we wanted to incrementally extend the periods of participation in therapy activities. And then in terms of choosing our consequences, we really decided on a timeout plan. So in that first session, we did that interview and assessment, and right away, I think we started talking to Father about what timeout was going to look like, and trying to set up a timeout in an office space, because that's where our goal was going to be. It was going to be in an office where he would be doing the testing to test the implant. And then we did, first of all, in my office, we did sort of a speech-language pathology simulation where I pretended to do therapy activities. I made a picture schedule of the 3 things we were going to do, and I made sticker rewards for when we got through an activity where he had to sit at a table and participate. And then we used timeout again and again and again and again. And I think in this case, my timeout, the length of timeout was about 20 seconds, I think. And I had a nice, on my computer screen, I just had a little visual timer that kind of, you didn't have to hear anything. You could just see the hand sweeping down, and then the timeout would be over. And then we also kind of crafted a corner of my office where he could sort of sit on the floor in the corner, and it's true he could hit himself against the wall, but basically it was a pretty safe, constrained place. And so then, because it was such a tiny area, Dad and I just got out activities, magazines, phones, and just made a real point of turning our back on the child during timeout, even though obviously we could hear everything he was doing and could be watching out for him pretty easily. So we did that, and that second session was quite exciting, but the funny thing is I actually think this particular father found it really a relief that that the tantrums weren't upsetting. And I think after going through it so many times and going through probably 25 timeouts in the space of one session, it ceased to become upsetting. And he actually did feel differently about the tantrums and really saw it more as a communication from the child rather than some terrible thing that had to be avoided. And so then the last session, we actually just moved it right over to the speech-language pathologist's office and did the same things. We used the sticker rewards, and we set up a little timeout in her office, and I think we had to change a little bit to put Tim in a little chair that had straps so he could be more restrained, because her office just had more things in it, so there wasn't really a safe place to let him be on his own. And then as soon as the timer was finished with the 20 or 30 seconds, then we right away got right back to work and seemed perfectly happy. We did not talk about behavior. We did not try and coach or reprimand. We just got right back to work. And it was a real test of my belief system that this was going to work. But within 35 minutes, in fact, he would sit and play with some of the activities for 1, 2, 3 minutes at a time, which was definitely more than he had done before. So the parent and the speech-language pathologist continued this for a month, and then went ahead and tried to do the testing for the cochlear implant. And the report that I got in an email was that Tim was alert and cooperative. He played with the toys. He demonstrated good behavior for most of the session. And most importantly, our SMART goal was met because the team was able to obtain results they felt were reliable about how his cochlear implant was working. So that's a really happy story, of course, and of course I'm going to give you a happy story. But I do want to point out again that it isn't important to be right the first time. And when we look at behavioral intervention, it is not finding the quote-unquote perfect intervention or the perfect strategy, because I guarantee that the perfect strategy is going to be short-lived. Anything that works is only going to work for a specific situation or a specific developmental period. And so really when we're talking about behavioral intervention, we're talking about a set of skills that are adaptable and flexible and that you're going to use differently at different times and for different purposes. So I actually think that these are the kinds of skills that parents use extremely effectively on their own. And I think the question I often get is, well, how do we know, if this is just regular old toddler behavior or child behavior that I can handle on my own, or is this something that actually needs a more concerted intervention or a consultation with a professional? And so I think, I come up with a little list here of red flags, of things that if you're seeing these things happen, you may want to consider getting some extra specialized help. And one would be if the behavior is interfering with participation in something that is very important and specialized. And so again, in kids with hearing impairment, that's most likely going to be speech-language pathology sessions, right? Because we know that the speech is so fundamental to the social emotional health of kids, to their learning and cognitive health. And so even though it isn't, I guess, fair to expect a little kid to sit through these kinds of formal therapy sessions, it is critically important. So if the behavior is getting in the way of accessing those opportunities, I would say that's a real red flag. Similarly, if the behavior is interfering with really important daily activities, so if every mealtime is a disaster, if sleeping, if the whole family is sleep deprived because there's no great sleep routines, or just the basic hygiene of washing, toileting, like these kinds of things that have to happen every day for everyone to be happy and healthy, if these are daily battles, that's another sign to me that, wow, this really is worthy of some dedicated intervention. And then I think, as parents, if you're having feelings of hopelessness, of feeling really isolated or feeling really overwhelmed, and those feelings are not just, once, twice a month, but they're happening regularly, and they're happening for more than a few weeks, I think parents are absolutely the best barometer of their child's well-being. And so if a parent is feeling that despondent, to me, that's really a sign that the child is in a situation of needing help, and the parents need, and you as parents need help too. And then, of course, all of these red flags, I sort of have the caveat of, that if these things are happening right after the birth of newborn twins or a move to a new state, well, then we might sort of take that with a grain of salt. But if these are just happening when there's not really any other significant changes or stressors happening, then that's another reason to maybe think about reaching out for help. So if we think about what a behavioral psychologist would do, or a therapist would do, a behavior therapist, I think the main thing is to listen carefully to the concerns that you have and help you prioritize the behaviors that are most important to change. They can help in setting those, developing those SMART goals for a desired behavior. And sometimes it's really helpful to have an impartial person developing a plan for how you're going to respond to those behaviors, developing it ahead of time, to really give you a chance to change those targeted behaviors. And then having someone that you can go back to and adjust and refine this plan over and over, that's really, really helpful. So like I said, we expect that behavioral plans have to change. That's exactly how they work. It is not something that you set out and you stick with for the next year. So effective plans, they may stay true to the core strategies, but there's a lot of creativity and individualization that happens. So if you're looking for a provider, this can be kind of tough. There's not a huge amount of pediatric psychologists or behavioral therapists that people can access to begin with, and there's certainly not a lot that have specialization with kids with hearing impairment. So what I would say about that is that it's really helpful, but not actually necessary for a behavioral therapist to have specialized knowledge about any particular condition. I would say it's absolutely necessary for that behavioral therapist who doesn't have that specialized knowledge to be able to acknowledge their lack of experience, to be able to ask or listen to you and responding to the unique circumstances that you're in, and then also to be willing to communicate with the other providers that are in the child's life. So, if you're looking around, I don't know if you Google, pediatric psychologist hearing impairment in your town, I doubt you're going to get a lot of hits. But if you have someone who's really good at behavioral interventions and they're willing to do a little communication and learning with you and your team, then I think that's probably fine. So, we brought this up in the beginning because, our goals here are really to help children access all the opportunities they can access and become as independent as possible. That is every parent's goal. And we know that behavior can really interfere with accessing those opportunities. And so our goal with these behavioral intervention strategies is actually to change things around so that children can actively engage with the different kinds of developmental benefits and growth opportunities that you as parents are developing for your kids. So this wraps up my webinar for today, and I know that in a month or so we're going to try and have a time for questions and answers, and I really, really would love to have your feedback, and I'd love to have questions, because I learn most of my best behavioral interventions really come from parents, come from working with parents. And so while I have some expertise in knowing about these particular strategies, I think actually coming up with the creative ways to make those strategies work in real life is something that is very much a team effort. So I would love to have your feedback. Please email your questions to Emma, and we have the email up there. So I'm going to turn it back to Emma, and we'll wrap it up.
Thank you. Like we both said, if you have any questions, please email them to that email that you see on the screen right now. The live Q&A session will air at a later date, which is going to be determined by availability. So keep an eye out on your email, and we will let you know the date and time of that. Just another reminder that the post-course evaluation will be sent out in a few weeks. We ask that you take a few moments to provide us good feedback and suggestions, such as future topics, format, time of day, etc. Like we said, our next webinar is going to be that Q&A session, and it will be sometime in the next few weeks here, and the date and time are to be determined. We would like to thank Dr. Van Tubergen for taking the time to present today, and for those of you watching this recording. Again, be on the lookout for that course evaluation, and we look forward to wrapping up our 2018 Parent Webinar Series with the Q&A session soon. With that, we will conclude today's webinar. Thank you for watching, and I hope you will have a great day. We hope to see you at our next webinar.